Alright guys, so we're going to get started with newborn, all things newborn. We're going to do newborn adaptation and newborn assessment, along with some aspects of newborn care and newborn discharge. So we'll get started with that. Newborns need to transition from being inside of mom to outside in the world with us, and there are many changes that need to occur. So the primary areas that we focus on in terms of assessment from the time the baby is born in those first few days are the respiratory, the cardiovascular, and the thermal regulation. Those are the three areas that you really need to focus on when you're studying. The rest are important as well, but the primary areas that I am usually concerned about are the respiratory, cardiovascular status of the baby, and their ability to maintain homeostasis. When a baby is born, their respiratory system has to convert to be fully functioning. When they were inside of mom, their lungs were full of fluid or amniotic fluid, and when they are born, they have to take their first breath and push fluid out into interstitial spaces. In order for the lungs to be able to expand with air, there's a substance called surfactant. Surfactant is produced in the lungs of the infant, and it's produced in the lungs of the fetus, so in utero, and it usually is sufficient by 34 to 36 weeks of gestation. This surfactant makes the alveoli in the lungs expandable. It makes them flexible. Without surfactant, it's very stiff and they can't expand to the capacity that is necessary for air to enter into the alveoli and then be able to, go through processes to perfuse the blood that is circulating throughout the system. So surfactant is a big factor when we talk about babies being full term or preterm. Full term is 40 weeks gestation. Anything before that, you are considered a preterm baby, and at 34 to 36 weeks is what we're really looking for in terms of adequate surfactant. So when you get to the end, it's really important to get babies through as many weeks as you can towards term, because a lot of changes happen during those times. So when we talk about a baby taking their first breath, it's really important that we understand that that first breath is crucial to that amniotic fluid that was present in utero to being pushed out into the interstitial spaces, so that air can occupy that space in the alveoli. It requires negative pressure, and four factors that contribute to this first breath there are chemical factors, there are mechanical factors, and there are thermal factors, in addition to sensory factors. So chemical factors that cause this baby to breathe is a response from baroreceptors within the aorta. So the baroreceptors in the aorta sense low oxygen levels once the baby is separated from mom. When that cord is cut, that baby's no longer getting oxygen. So when there's low levels of oxygen in the blood, the baroreceptors in the heart send a message to the respiratory center, the medulla within the brain, and the brain then sends a message to the lungs to breathe and to function. So that's the big chemical factor that occurs. Mechanical factors include that motion that happens when a baby is squeezed through the vaginal canal being born. So when that baby is squeezed, it's kind of like a spring. You kind of compress the spring, and then there needs to be, they're squeeze, squeeze, squeeze. It's actually mechanically pushing fluids out of the baby's mouth as well, but it's pushing fluids into the interstitial spaces. And then when the baby is expelled, it's like a recoil of the chest, and it springs open so that that is a mechanical feature of the baby's first breath. Thermal factors are important. If you think about if you were to jump from a hot tub to a regular swimming pool, what is your first instinct? Mine is always to take a deep breath. So if I jump into the pool, it's cold. That's what a baby's doing. They're coming from a hot tub into a swimming pool. So that initial shock of temperature change causes them, stimulates them to breathe as well. And then, of course, other sensory factors that are present outside of a uterus that were not present inside the uterus. Babies can hear, obviously, in utero, but they don't hear as clearly or as crispy. It's like being underwater. And babies also now can smell things, they're being touched, they're feeling different textures. Those also contribute to the baby taking their first breath. If you're more of a visual learner, this kind of just shows you in the picture format what happens when a baby is born and what starts the infant's respirations. In the cardiovascular system, two major changes occur. The placenta is clamped, so we are cutting off the blood flow through the placenta from mom, and the lungs fill with air. So if you're thinking about the cardiovascular system, you can't help but think about the respiratory system, because the cardiovascular system in the infant is dependent on the fact that that baby takes their first breath. So they're very closely linked and connected. There are three huge changes that occur in fetal circulation. We're going to go over them. I want you to really focus on the third one, the ductus arteriosus. But the ductus venosus is also important in terms of this is a vessel in fetal circulation. So when baby is on the inside, that shunts blood away from the baby's liver. The liver doesn't need to function as it does because who's filtering the blood for the baby? Mom. So the function of the liver in utero is less than it will be when the baby is born. When that placenta is clamped, there's a pressure change, and the blood flow then goes to the liver, and it starts filtering on its own. This ductus venosus, this bypassing vessel, usually closes within 1 to 3 days. So that is when the baby kind of fully has to start taking over, filtering out its own blood. The foramen ovale is within the heart, and this connects two atria, the left and the right atria, and this is shunting blood away from the lungs. Again, we don't use our lungs as we do in utero, and we don't need to. We don't have to filter air and distribute it. Mom's doing that for us. So when air enters the lungs, it causes low resistance to blood flow in the lungs, and that decreases that blood flow from the right atria to the left atria, and it closes over. This happens within minutes of the baby being born. This foramen ovale closes up, and we no longer are shunting the blood away from the lungs because now we need to perfuse our lungs. The third change is the ductus arteriosus, and that usually occurs within hours of the baby being born. This is a shunt between the pulmonary artery and the descending aorta, and this also shunts blood away from the lungs. This is the one I really want you to focus on because this is the one that most commonly stays open for a prolonged period of time after delivery. Babies who have a period of asphyxia or a period where they don't get enough oxygen in delivery or in utero may have a patent ductus arteriosus for a period of time after birth. Usually about 24 hours is normal, and even though it's normal, we still would report it. So we would want to let the physician know. Sometimes they order 4-point blood pressures. We don't typically take blood pressures on babies, but in general, like as a standard of care, they don't need a blood pressure with vital signs like adults do. But in the case of a patent ductus arteriosus, you would want to verify blood pressures, and they do both upper extremities and both lower extremities. So if you were to hear, wink wink, this is a circle star smiley, if you were to hear a murmur on a baby, and you identified that as a PDA, or a patent ductus arteriosus, you would want to report that to a physician and verify, at least make them aware. Again, they may order those 4-point blood pressures. At the bottom of the slide, there's fetal circulation at birth. That's a link to a video that shows you kind of the nitty-gritty of fetal circulation. If you're the type of person that really needs that, I recommend it. I am not going to test you on the nitty-gritty. I want you to know that if a baby has one of these fetal circulatory changes, that maybe it's prolonged and it doesn't occur as it should, you may hear a murmur in your baby, and that the most common one is a PDA. Newborns are at a risk for hypothermia primarily, and there's a couple characteristics of a newborn that make them more vulnerable to heat loss. They have a very large surface area compared to their size, so they are more prone to losing heat. Their head is a lot bigger than their body, and we lose a lot of heat through our head. In addition to that, they have very thin, fragile skin, so they are more prone to losing heat in that way as well. The methods of heat loss that you need to know and be aware of are evaporation, conduction, convection, and radiation. And on the next slide, there's some nice pictures that coincide with these. Making sure that you know the definition. It's important for you to know the definition of these terms, and also know what we can do to minimize each of these methods of heat loss as nurses. So I'm going to start in the top left hand corner. That's evaporation. Evaporation is from being wet. So that's why when the baby is born, we try and dry them off very quickly. If they have a wet diaper, we want to change their diaper promptly. They can have insensible water loss from their lungs that when they breathe. And especially when they're taking a bath, we want to make sure that, we have to clean them, but we want to dry them right away. They lose heat more easily when they are wet. So that is why we dry them off quickly. Conduction occurs when the infant comes in contact with cold objects or surfaces. This conduction occurs when the baby is touching something that is colder than them. So any object that the baby is touching that is a lower temperature than them is going to draw heat off of them. So for instance, in the picture, cold hands, if the crib is cold, that's why we tend to keep babies skin to skin, because moms are nice and warm, and they can increase their temperature by doing that. Nurses also, put stethoscopes on their bare chests. It's important to warm up that stethoscope before you're putting it on the baby's chest, and avoiding drawing heat off of them. In the bottom left-hand corner, we talk about convection. This occurs when air currents are moving around. So in the picture, you can see the air conditioner's on, the open door in the hallway, if a window is open. So convection is heat loss by air. So we need to, not put baby directly in front of an air conditioner. Make sure especially when bathing, that the room is free of drafts. And then the final method is radiation, and that is just the baby being close to cold objects. So conduction is when they're actually touching them, the cold objects are touching them, and radiation is when the heat is being drawn off the baby by just being close to cold objects. So for instance, that baby's placed near a cold window, cold walls, basically anything around them is going to be a lower temperature and is going to pull heat off of them. So it's really important that we keep them, if they are in the crib, they need to be swaddled. And if they're not in the crib, they need, skin to skin and wrapped in visitors' arms. The other aspect of a newborn that makes them difficult, it makes it hard for them to maintain their temperature, is they don't have the ability to shiver. So they do this really cute lip quiver, and it's funny because parents are always like, "Oh, they're cold," and I'm like, "No, it's not really cold. They can't shiver. It's just a cute little lip quiver." So non-shivering thermogenesis is brown fat, or the use of brown fat in a baby. So babies are born, full-term babies are born with brown fat, and there's a picture on the next slide of where that brown fat is located in their body, and it really makes sense because they're areas of high blood flow. So these areas of brown fat are it's an area that if the baby needs to increase their heat, they will burn off this fat, and the increased metabolism in that area of those cells generates heat, and that those areas that the brown fat are around are places of big vessels. So for instance, it's usually around the heart, the kidneys, the adrenal glands, and by using up that brown fat and burning off that energy and creating that heat that then those big vessels are going by or through, it brings warmer blood to the rest of the body. Amazing. I just think it's amazing. So in that third trimester is when brown fat is primarily developed. So that's another reason that it's really important for babies to be born at term when possible, because they won't be born with the stores of brown fat if they are born preterm. It takes those final weeks to kind of build up that brown fat. We talk about cold stress, and cold stress is a really important concept that you need to know for your quiz, for your test. Star, circle, smiley it, highlight it, whatever you need to do. And we're going to talk about cold stress. It affects so many systems in the newborn. So when I talk about cold stress, is what I'm saying is the baby doesn't maintain their temperature. We don't pick up on the fact that their temperature is dropping. And then when they are cold, all of these other processes start to happen. So what is typically the end result are those 4 bullets underneath that affects a cold stress. So increased need for oxygen. They need more oxygen, so their respiratory rates go up. Decreased surfactant production, which means they have less expansion in their lungs to get oxygen to their tissues. They increase their need for glucose, so they are more likely to become hypoglycemic. And then they're also at risk for having a metabolic acidosis, because when they are metabolizing that glucose in the absence of oxygen, one of the byproducts is acid production. And then, because they are increasing the amount of acid production, they are also putting themselves at risk for jaundice. Jaundice in newborns is fairly common. So those increased fatty acids in the blood system interfere with the ability of bilirubin to be transported and excreted from the body. So all of those processes are happening just because the baby got cold. So I'm going to go into that a little further in upcoming slides, but a neutral thermal environment for a clothed infant is 75.2 to 80.6 degrees Fahrenheit. You do not need to commit that to memory. What you need to know is keep the room warm, okay? And we do warm it for delivery. We tend to warm the room up for delivery. We talk a lot about hypothermia, but babies are at risk for hyperthermia. They can't regulate their temperature down any better than they can regulate their temperature up. So with hyperthermia, the risk is too many blankets. Oh, I want to keep the baby warm, so I swaddle it 3 times. Now that's a little bit extreme. So we don't need to go that far, but if they are hyperthermic, it increases their metabolic rate again, and then we have some similar issues as to hypothermia. So keeping them in a neutral thermal environment is key to keeping them normal thermic. So this is the slide of the baby's brown fat. This is where that brown fat is located. Again, makes sense. It's by big vessels because when they burn it, then they can transport the heated blood to all the areas of their body. So this is one of my favorite slides. I think it really pulls together a lot of different concepts. Across the top you have evaporation, which is heat loss by water, conduction, which is heat loss by objects touching the baby, convection, which is heat loss by air, and radiation, which is heat loss by objects not touching the baby. All of those can contribute to a low temperature in the newborn. A temp less than 97.9 is too low. I know that the slide, it looks like that it got cut off there. It looks like 97.7, but it's really 97.9 degrees Fahrenheit. It must have gotten skewed when I scanned it in, but when that baby's temp is approaching 97.9 or below, they are going to attempt to maintain their temperature on their own, and how they do that is flexion of the arms and legs. Okay, so they bring their arms and legs closer to their body. They kind of curl up in a ball. This is an attempt to decrease their surface area, which therefore prevents heat loss. The other thing they might do is increase their activity, cry. Those are ways that they can increase their temperature. So think about it, when you're cold, you might kind of hump up and down or something like that. Kind of jiggle your leg or whatever, rub your hands together. That is meant to kind of generate heat, and a baby, that's what babies have to do that. If they are unsuccessful, and if we are unsuccessful in identifying a low temp in a baby, then all of these processes can occur. I'm going to start over on the left hand side with the increased metabolic rate. When their metabolic rate increases, they have an increased demand for glucose. They can become hypoglycemic very easily, and in a baby, a blood sugar less than 40 is considered abnormal. So babies who have a blood sugar less than 40 are considered hypoglycemic. I will tell you that that number is under scrutiny right now. There's a lot of research being done to determine at what number, in terms of a glucose level or a blood sugar level, is the baby's brain able to function. There are some facilities that are going by a lower number right now. I would not recommend going by a lower number than 40, but there are a lot of facilities who are leaning towards a higher number, like closer to 50. So for right now, in practice, 40 is what we're going to use for testing purposes, but just know that in the future that may change. The increased use of oxygen decreases the production of surfactant. It leaves the baby in a hypoxemic state, which then increases their respiratory demand. So they are going to probably show signs of respiratory distress. Those 4 signs of respiratory distress you really need to commit to memory. Respirations greater than 60, nasal flaring, so they're really working hard and their nose is kind of flaring at the sides. Grunting, so we call it sing-songing sometimes when we are in practice and talking to one another, but grunting is when they are really working so hard to push air in and out of their lungs that they actually have like a little bit of a moan or a whine with their respiration. So I'll do it, but don't make fun of me. Like that, and they're just pushing so hard, and it's just their effort, it's their respiratory effort. And then retractions. So retractions or intercostal retractions, meaning that you can see the skin kind of tug in and out around the ribs, and the baby is just using all of its accessory muscles in order to breathe and push air in and out. The metabolism of brown fat is in the middle. With that metabolism of brown fat, they're making an attempt to increase their temperature. But by doing that, they are increasing the production of acids in their blood. So they can become metabolic, they can enter a state of metabolic acidosis, which is a pH less than 7.3. I don't need you to remember that number, but I need you to know that that increased amount of acid makes it very difficult for bilirubin to be eliminated from the baby's body. That acid takes up binding sites on albumin, which bilirubin needs to be excreted from the body. So the acid displaces the bilirubin, and then the bilirubin is free flowing in their blood system, in their bloodstream, and causes them to be jaundice or yellow. Over on the right hand side, we also have vasoconstriction going on to try and decrease, conserve in a way. So the peripheral vessels vasoconstrict, and you can have pale, cold, and mottled skin in your newborn. The pulmonary vessels constrict as well, so more in a central way. And kind of stay with me on this, it's a little bit confusing. If you have constriction of that pulmonary vessel, it's causing resistance in that vessel, okay? And as a fetus, you had pathways in place as a fetus that were shunting blood away from the lungs. We've already talked about that. So when you have this vasoconstriction of that pulmonary vessel, you can have a return to fetal circulation. And there's right to left shunting through the ductus arteriosus in the foramen ovale, which is away from the lungs, which then that blood is bypassing the lungs. And we have low oxygen in the blood that's going out to the baby's body, which further puts the baby into respiratory distress, and also could have an impact as well on the baby's heart rate. It would also increase the baby's heart rate. A normal infant heart rate is 110 to 160. That's on a future slide, but it would also increase, the demand on the heart to pump blood through, because lower oxygen, it's going to work harder to perfuse the system. Factors that affect the blood is time of when's the cord clamped. There's something called delayed cord clamping that is pretty much the standard of care. It used to be that we cut the cord right away. We found that it gives babies a little bit of a boost for their first few days of life if they get all the blood in that umbilical cord. So we don't clamp the cord until it stops pulsing, okay? So we don't cut the baby's cord and separate that baby from mom until the cord is done pulsing. It just gives them an extra, it's like a transfusion at birth kind of a thing. It kind of gives them a little bit of an increased stability hematologically. Term babies are more hematologically stable than preterm babies, and we usually try and position the baby lower than the placenta while it is pulsing to get the most out of the cord that we can. I will say that cord clamping is, it was a little bit controversial. I guess it still is. In babies that are getting that extra dose of blood, we have to consider that they have an immature liver. So if you're giving them extra blood into their system, those red blood cells eventually are going to break down, and the liver is going to have to process them, and one of those byproducts is bilirubin. And when we have that bilirubin in our system, we can become jaundice. So if we're putting that added stress on an already immature liver, that was a little bit of a controversy. But the benefits of delayed cord clamping far outweigh the risks of jaundice, and we can treat jaundice too, so if that does occur. I'm not saying cause it, but I'm saying that the benefit of that little blood transfusion at delivery is better than not having it. Another issue hematologically with a newborn is the risk of clotting deficiencies. Babies have very fragile vessels and are very prone to bleeding. And in addition to that, they lack vitamin K. They don't have any vitamin K in their system when they are born. So we give them vitamin K to assist in their ability to clot their blood. Before vitamin K, babies died. because they had brain bleeds or vessels rupture, and then they bled out because they didn't have the clotting factors that they needed. Um, we do need to get consent from parents on this. Parents are sometimes in this day and age refusing this vitamin K. It is their right. They will be counseled by the pediatrician. Depending on the pediatrician, they'll call in social services or sometimes even CPS. I've seen that happen because they've refused the vitamin K. But, it really is one of those things that it's a vitamin. It is an IM injection, so the baby does get a stick in their leg. But like I said, babies died because they bled out due to lack of appropriate clotting factors. So it's a pretty crucial intervention, I would say. But that being said, that's just my opinion. And we all know that when we're nurses, our job is to educate. It's not to give an opinion. So we give them all the risks and benefits of what we're doing, and then it's up to them to really make a choice. And you have to decide if you can live with the choices that they make. And I think that working with babies, that adds a whole new dynamic to that. There's a link there that you can click. It's a little information on why people refuse vitamin K, and why vitamin K is so important not to refuse. So take it as it is. The stomach, the capacity of the stomach expands within the first few days of life. Peristalsis is very rapid. It's which explains why they go to the bathroom a lot. And the stomach in the first few days is only about the size of a ping pong ball. So that also explains why we have to feed them so frequently. About every 2 to 3 hours if they're breastfeeding, and about every 3 to 4 hours if they're formula feeding. Babies also throw up a lot, and it's due to the fact that they have this reflex, this gastrocolic reflex, that's stimulated when the stomach is completely full. Okay, so when they fill, it's like a gas tank that, you're pumping the gas and you don't listen to that click and you just overfill it, and then the gas pours out all over the ground. That happened to me twice this week. But they also have a relaxed sphincter that also leads to regurgitation. So they are very prone to vomiting. The intestines are very long in proportion to the infant size. There's more surface area for absorption, so that's a good thing. We want them to get as much out of whatever we're putting in as possible. They're more prone to rapid water loss with diarrhea. So a day of diarrhea in a newborn is a big deal. You want to give a call to the pediatrician. You don't want to let that go very long. They are more prone to becoming dehydrated very quickly. Their bowel sounds are present within the first hour, and their digestive tract is sterile until feeding begins. So once we start feeding them, then they can start to build like a bacterial flora. Stool in a newborn, we pay close attention to poop in our area, okay? And it progresses as we start to add food into their system. Their first stool is a meconium stool, and it is black and thick and tarry. It's very sticky. It's the first stool that is passed, and it's really a collection of particles of amniotic fluid because the baby hasn't had to go to the bathroom in utero. Some babies do. We'll talk about that when we get to labor, but they don't really need to. So this is kind of a collection of what they've accumulated since their creation. And like I said, it's thick and tarry and sticky. It's really a great first diaper to do for those new parents if you can walk them through it. And it's a lot of work to get that off of their little tushes there. So meconium is the first stool. And then as we start to add milk into things, whether it be breast milk or formula, it turns to a dark green, yellowish kind of a color. And it's because it's a combination of meconium and milk stools. So we have a transitional stool, and that's a darker green in color. And then we transition to milk stools, full-on milk stools. And what those stools look like depend on how you're feeding your baby. Are you breastfeeding your baby or are you formula feeding your baby? So breastfed baby stools are seedy and are like a mustardy color. And it's so funny. I have students who ask me, "Oh, is it like a, what is that? A bright yellow mustard or a spicy brown mustard." I'm like, it's mustard, I don't know. And then these stools are more frequent than with formula fed babies. It's digested more rapidly than formula is. And these stools have a sweet, sour smell. So, a benefit to breastfeeding, your baby's poop doesn't smell as bad. And then formula fed babies, the stools are pale yellow to light brown, and they're more firm in consistency because the iron more is present in formula is present in higher levels in formula than it is in breastfed babies, or in breast milk. Wow, that was bad. The stools have a characteristic odor of stool, so they do tend to have stinkier stools. It's important that you know the progression from meconium to transition to milk stool and the characteristics of each. Circle, star, smiley, that. All right, so the conjugation of bilirubin. The source of bilirubin and the effects of bilirubin are dependent on the fact that we have a baby who has a lot of blood in their system and they are breaking those red blood cells down. Erythrocytes or red blood cells die off quicker in a newborn than they do in an adult. So they have higher levels of toxic product to filter out. And bilirubin is a toxic substance. That immature liver must convert to a soluble form or become conjugated to be excreted from the bowel. If you have unconjugated bilirubin in the baby's bloodstream, it causes jaundice or a yellowing. If it's present at high levels, you can have bilirubin encephalopathy, which then you're starting to cause neurological damage within the baby's brain. And then kernicterus is the most severe level of this, and it actually causes permanent brain damage. So we really need to be on top of babies' bilirubin levels, and we're going to talk about the testing for that later on in this PowerPoint. This is more than you really need to know. I'm going to sum up this whole slide with the fact that there is a process within babies that actually can take bilirubin that they have conjugated to be excreted, and it converts it back to being unconjugated to then needing to be conjugated again. So, they almost have, so this process within newborns, it means that they may have to actually go through the process of conjugation twice, which is not fun, and it puts them at higher risk for jaundice. So what are all the factors that make a baby at higher risk for developing hyperbilirubinemia, meaning too much bilirubin? They make too much of it. Red blood cell life is shorter in a newborn, so they are rapidly depleting, hemolyzing their red blood cells, which means there's more byproducts for them to process. They may have inadequate amounts of albumin that make it difficult for them to transport unconjugated bilirubin out of the baby's system. The liver is immature, so it can't keep up with all these byproducts of the breakdown of red blood cells. Blood incompatibility, we're going to cover that a little bit later in this slideshow. It has to do with when a mom's blood type is either O or they have an Rh negative factor. Like I said, we'll get a little bit heavier into that a little later in this presentation. Gestation, full-term babies do better than preterm babies, just for the fact that their liver is even that much more developed in those last few weeks of gestation inside of mom. Trauma, so if they have any kind of trauma at delivery that causes any bruising. That's an additional amount of red blood cell byproducts that they have to process. And fatty acids. Fatty acids, again, can take up that albumin. So like in cold stress, like we discussed, if there's a lot of fatty acids present, they can it can be taken up in those albumin binding sites that are needed for bilirubin to be transported. And then a family background. There is a family history of difficulty. It is hereditary, and so if a previous sibling had to have phototherapy, which is the treatment for hyperbilirubinemia, then this child, a current pregnancy may have that issue as well. Another thing is males are also a higher risk for developing jaundice, just in general. So if it's a male baby versus a female baby, they do have a higher risk of developing jaundice. We're going to talk about different types of jaundice. You should know the difference between each. So mainly physiologic and pathologic. Those are the two that we really focus on. Physiologic jaundice is considered relatively normal. All babies to some extent will experience some level of jaundice, and jaundice is visible when the bilirubin level is greater than 5. So that's just when we can start to see that their skin is yellow. It doesn't necessarily mean that that's a dangerous level, but that's when we would start to pick up on it on assessment. Psychologic jaundice is transient, so it means it's going to come and it's going to go and it's going to be okay. It's never present during the first 24 hours of life. It usually shows up around 2 to 3 days after birth. And one of the big things with jaundice in general is the rate of rise and fall of bilirubin level. So the older the baby is, so the higher their bilirubin level can be to a certain extent without it being a bad thing. So you need to write this down. 8 is the level at 24 hours. We check all babies at 24 hours, and we do not want their bilirubin level to be higher than 8 at that point. That's the marker that we use. So if you have a baby who is, say, 8.5 at 48 hours, we're not really that concerned. It hasn't, the rate of rise isn't too bad. But if you had a baby at 18 hours who was 9, that would be a concern. And then we would have to maybe do something about it. And this physiologic jaundice, like I said, is considered normal. A lot of babies will experience some level of jaundice as long as it's not too high for the number of hours old that they are. Pathologic jaundice occurs within the first 24 hours. So that's how you're going to determine the difference between the two. This is caused by some underlying abnormality that's causing excessive destruction of red blood cells, or it's an issue with the conjugation of bilirubin. So there's something going on underneath, as opposed to, oh, the baby just has a little bit of extra blood on board from delayed cord clamping, something like that. This is more, there's some process is not happening as it should, and these rates rise quickly, higher, and they last longer. So the big differentiation between pathologic and physiologic, is that rate that this pathologic occurs within the first 24 hours, and the physiologic occurs in 2 to 3 days. These two we don't talk about as much, and I wouldn't focus as heavily on breastfeeding jaundice. This means that a baby becomes jaundiced because they have poor intake. In order for them to have a normal level of bilirubin, they need to start pooping it out. And if they don't feed right away and they have difficulty breastfeeding, so they don't have good intake, the baby might have a poor suck or be sleepy. It would delay the elimination of that meconium, the transitional stool, and then depending on what they eat, if it's a formula stool or a breastfeeding stool, any delay in excretion is going to delay the removal of bilirubin from the baby's body. So breastfeeding, can take some time, and this again is more of a transient thing. All we have to do is get them feeding and it will resolve. Sometimes we do have to put them under phototherapy until feeding is resolved, or feeding is, well underway. True breast milk jaundice is very rare. Bilirubin levels rise after the first 3 to 5 days, and it's actually, there's a substance within that breast milk that interferes with the conjugation of bilirubin directly. We closely monitor the bilirubin levels. It can last 3 weeks to 3 months. They kind of can grow out of it. And whereas their liver would catch up with that interference of conjugation, so their liver would kind of mature. Some require treatment and phototherapy, and they may have to supplement with formula for a period of time to decrease their bilirubin levels. So we just talked a lot about the bilirubin. When we talk about the hepatic system, we talked already about blood coagulation and receiving vitamin K. So that's what this is all about. When we talk about iron storage, a baby stores a lot of their iron in the third trimester in pregnancy. So they do have enough to really be carrying them through the first few months of life. And then if they're formula feeding, they do get supplemented, they get that within the formula. So iron isn't really a huge concern. There is some in breast milk. There's some, but a lot lower levels than what's in formula. And the iron that is in breast milk is more easily digested by the baby. So it's, even though there's lower levels of it, they get what they need because they can absorb it better than they can through other methods like formula. Metabolism of drugs, we just have to be cognizant of that in relationship to the hepatic system because they cannot take high doses, obviously. So we have to be very strict with that, and you'll see in your math guide that we go out to the hundredths place for doses just to be as specific as we possibly can, and they're always weight-based. Kidneys, our urinary system, the kidney development is just as immature as your liver. So kidney function is not up to what it is as an adult. It takes some time for it to catch up. Fluid balance is difficult often to achieve. We've talked a little bit about that in terms of they can become very dehydrated very quickly in times of diarrhea. They can become constipated quickly. Urine, they can't dilute or concentrate their urine, so their kidney does not have the ability to hold on to water when they need it if they are dehydrated, or remove it if they are hypervolemic. So they don't have a good way of balancing their fluid initially as newborns. So we do take great care in assessing that fluid balance by taking a strict INO. The immune system of a baby, as we all know, it used to be that you had a baby and you really didn't leave your house. It was kind of like the coronavirus was out. But this now I do see more babies in the community outside of right now, and it kind of makes me cringe a little bit. They do not have the immunity in order to be out in public. I think we are becoming more aware, especially with higher rates of RSV during the winter. Babies are very vulnerable. They don't have the immunity yet. Their body hasn't been able to develop it. Their immune system has to be exposed to infection in order to really build up that immunity to be in the world, which we need to do, but we need to do it slowly over time and allow for that baby to develop that immunity. So immunoglobulin G, they do get from mom. It's maternal to fetus. So IgG, it crosses the placenta and gives them a temporary immunity once they are born. IgM is produced by the fetus. This is the first immunoglobulin that is produced when the baby is exposed to infection. So you bring it home, they are going to be exposed to bacteria in the world, obviously, and their immune system starts to rev up and develop a response to living in the world, basically. Immunoglobulin A, or IgA, They receive some from colostrum and breast milk, so that is one of the benefits of breastfeeding. That colostrum is what they get in the first couple of days. We're going to talk about more about colostrum and the progression of breast milk in the infant feeding section of this PowerPoint, not this one, the second half of this one. But other than that, it must be produced by the baby. So this baby has to, just like IgM, we have to build that immunity. All right, so psychosocial wise, I think it's funny when we talk about the psychosocial aspects of a newborn. It's kind of fun. But they do go through a few different standard states. So they have something called a first period of reactivity. So from the time that they are born to 30 minutes of age, they are usually very alert. They are aware of their surroundings. Eyes are wide open. They're usually looking all around the room. That is a very, very important time. We usually limit that period of time, even the first hour after delivery, we call it the golden hour, because this is an awesome time for bonding and initiating feeding. So whether it be breastfeeding or bottle feeding, this baby is awake, alert. They have just been the cord has been cut from mom, so they have to start doing things on their own and getting food from us as opposed from a cord into their belly. So this is a really, really important time for them to kind of meet their baby, check them over, start feeding. So we usually limit that to mom and their significant other for a good period of time, about an hour. After that 30 minutes, they tend to fall asleep. They're tired. They've had a rough road as well. Okay, so mom's exhausted, baby's exhausted. There's a period of sleep. Their pulse and their respirations fall, and they can sleep for up to 4 to 6 hours. So if you miss this window, this 30-minute window of time where you can initiate bonding and feeding, then it's really hard to get them to wake up and eat during this period of sleep. So we always try to really get that 30 minutes in with just mom and the significant other and baby and get them to feed. After they've slept it off, okay, after they've slept off that first, entrance into the world, because it's a lot, it's very stimulating for them, and it's all new. So the second period of reactivity starts around 4 to 6 hours, and they wake up and they're interested in feeding again, which, if we've talked about, we have a little bit about the time frame for feeding. We tell moms, oh, you have to breastfeed every 2 to 3 hours. If you're formula feeding, you need to formula feed every 3 to 4 hours. Well, a baby can sleep for 4 to 6 hours immediately after delivery. So what do you think happens with mom? Mom gets nervous. Oh my goodness, the baby's not waking up to eat. It's fine. It's normal. We need to educate them, and also just let them sleep as well. They're tired. So this is usually the path that most babies follow after birth, and you should know those for your exam. You should also know the different behavioral states, and when I say you should know them, I'm saying that you should know what it means for nursing, that we need to initiate education during these times, initiate feeding, provide support during times where feeding is appropriate. If I say on a question, what is are you to initiate feeding during that period of sleep, you're not going to wake that baby up. Babies do not eat when they do not want to. It's really stressful, actually. But then identifying among these behavioral states when the baby is ready to eat. I know it sounds silly, but we're really focused on when they eat, when they pee, when they poop, and what their weight is. In these deep or quiet sleep states, so this is a state that you would find a baby, and it's probably what they will look like during this period of sleep and initially. You can pick up their arm and it just flops back down. These kids are out. There's no kind of really arousing them, waking them up during these deep or quiet sleep states, and they just will not wake up to eat. So that would not be a good time. That would be a good time to tuck mom in and tell her to take a little break. Light or active sleep state, again, not the best time to be waking them up. Their eyes are closed and sleeping. They might stretch or move. Kind of be a little bit fidgety, And they can be awoken from this state, but it's not really, they're not hungry enough to wake up on their own, so it might be a lot more work to get them to do that. In a drowsy state, their eyes are open or closed. They have kind of a glazed over look if their eyes are open. They're kind, they're drowsy. They're kind of in between sleep and awake. They can be awoken from that drowsy state to eat. So if you have a kid who hasn't eaten in 3 or 4 hours and they're in this drowsy state, the biggest intervention that you can do to get them to wake up and be interested is to put them skin to skin with mom. So we put them right skin to skin on mom's chest. It's just like Corey. If you bring Corey to the restaurant, she's going to order a cheeseburger. If you don't bring her to the restaurant, she doesn't have the option. So we want to put babies at the restaurant, skin to skin with their moms. Quiet alert state and active alert state are the best times for bonding and feeding. So a quiet alert state, they're kind of looking around the room, just gazing. They're not, they're not fussy at all. They're just content with the world. And this is really the best time to initiate feeding and to kind of pick up on this state that the baby is in and put them skin to skin, and they will likely feed within a half an hour. There are studies that show that babies who are put skin to skin in this state will latch within 30 minutes of being placed there. The active alert state, again, is another good time for bonding and interacting. They might be a little bit more restless. They might start to be a little bit fussy because we've kind of missed this quiet alert state where they're content and happy and we can kind of initiate feeding. So this is where we're kind of getting out of the zone again to get them to latch and eat. Once they hit this crying state, it's all over. They're screaming, they're mad, they're arching their back, they're frustrated, they're hungry, and they don't know why. You really have to, it might take a period of comforting, a little bit of time to comfort them and get them down from being so angry so that they can latch. A lot of them have difficulty coming out of that, that crying state sometimes. And that's when mom gets really frustrated. So it's really important that we give them support. Maybe take the baby the first time that this happens so mom doesn't get so stressed out, and thereafter encourage her to be more independent and calm her own baby down. It will empower her that she can do this, and that motherhood isn't that scary. I mean, it really is, but it's pretty, we got to send them out with some level of hope. Okay, so that kind of ends our adaptation portion. Now we're going to go into newborn assessment and nursing care. And this right here, this link in the PowerPoint is to a site by Stanford University, and everything that we've talked about, that we're going to talk about with newborn head to toe assessment, there's great pictures that you can go through in this link. It's got great photos of a lot of the things that we're going to discuss, and I just think it'll give you that visual that you're going to miss because you're in an online setting as opposed to being in the hospital. So please take some time and access that link. It's really beneficial. So the first part of infant assessment we're going to talk about in terms of how do we take care of the baby at birth, because it's a little different from the time that they're born to about 4 hours of age, and then after that we can space out their assessments. But initially at birth to 4 hours of age, they require close monitoring. Before a baby is born, before we go and attend a delivery, now different labor centers are set up differently. The ones that we would attend do have a nursery nurse who comes in and takes care of the baby at delivery. So if you were that nursery nurse and your responsibility was to take care of that baby at delivery, or this applies also if you're just taking over in a postpartum room and the baby is 24 hours old. You want to go in with this background knowledge. You want to know about these things before you enter that room and assess that baby. So a lot of it you'll get from report from another nurse. Or if you are attending a delivery, you're going to get this information from the bedside nurse who's taking care of mom during labor. So how was mom's pregnancy? How did her labor go? Were there any issues with labor? And have there been any issues in terms of delivery, or were there any issues from delivery? We're going to go about, talk about all the different things that can go wrong with pregnancy, labor, and delivery in upcoming units. But for right now, just know that you need to investigate all three of those areas. What's the baby's gestational age? And this is important because we have a gestational age that we assume is correct. Those gestational ages are always give or take 2 weeks. And we also have to remember that people don't always have the correct dates. So when you first see a baby, you want to be looking for signs that that baby is the actual gestational age that we anticipated, that it is actually a term baby, and maybe the date, that the dates were not incorrect. Maternal risk factors that we need to discuss are mag sulfate. Mag sulfate is a treatment that is given to moms with preeclampsia. And if mom had preeclampsia during her pregnancy, well, not during her pregnancy, but during her labor and her delivery because she was preeclamptic, that we give a high dose of mag sulfate, and that is transported to the baby. So if mom's on mag sulfate and then the baby delivers, there's a big risk for respiratory depression. Okay, that is the main thing in terms of baby that we need to think about when a mom is delivering who is on mag sulfate. Same thing with narcotics. If mom has a history of drug use, or maybe mom's on Suboxone, those are going to be indicators that we need to assess this baby, not only for respiratory depression, depending on how recent her drug use was, but also signs of withdrawal as we assess this baby later on in their hospital stay. Knowing their social history, who's present with mom, who's her support system. Maybe it's a teen mom and she's going to need a little extra TLC. Getting all of that information. Is dad involved? Is he not involved? Is he allowed on the unit? There's a lot of drama that goes on labor and delivery unit, and sometimes getting that social history is a little bit difficult. But direct questions are always best. Rupture of membranes. How long was that amniotic fluid sac broken? The longer it's broken, the greater the risk for the baby to have infection, and we would look for signs of that if there was a prolonged rupture of membranes. RH status. We talked a little. I mentioned blood incompatibility being an issue with babies becoming jaundice. Again, I have a whole slide on that coming up, and I will thoroughly go over it, but for now we just need to know that we need to know what their RH status was, because we want to identify that as a risk factor for jaundice. Delivery trauma, we want to know if there was any difficulty with delivery, and APGAR scores, which we're going to go over on the next slide. APGAR scores are something you should know definitely inside and out. So APGAR scoring was developed by Virginia Apgar many, many moons ago, and she decided that we needed a way to assess a baby quickly at delivery. So it's completed at delivery. We do it at 1 minute and 5 minutes of age, and then every 5 minutes until above a 7. It provides a quick window into, is this baby doing well or not? So it's out of 10 points, and anything above a 7 we can kind of rest easy, and a score of 8 or higher means that the baby didn't really need any resuscitation. Okay, so we look for higher APGARs that lead us to the fact that the baby was stable at delivery. If you have a baby with an APGAR of 2, that's obviously very bad. So if you had a baby with an APGAR of 4, you would have to continue these every 5 minutes until that score was above 7. Suppose you get to your third 5 minutes and that APGAR is a 6, you are going to have to continue your efforts until that score is above 7. So babies with low APGARs are not going directly skin to skin with their mother. they need to be worked on. So if you had an APGAR of 9, that baby's good. That baby can go to mom's chest immediately for skin to skin. We aren't really concerned about that baby. So being able to identify the number in terms of the APGAR is something you should know. And what does it mean in terms of the nursing care of the newborn at delivery? All right, so the mnemonic for APGAR that we can follow is A is appearance, P is pulse, G is grimace, A is activity, and R is respirations. They receive points based on the quality of each of those categories. If a baby is pale or blue, they get no points. 1 point for blue extremities and a pink body, and 2 points for a body and extremities that are pink with no cyanosis. So obviously this is a column that is a good baby. For pulse, all we're looking at is it present, is it below 100, or it is above 100, and based on that they are assigned a number. Grimace has to do with their response to stimulation. So if we stimulate them and there is no response from this baby, they continue to be floppy or flaccid. We're going to talk about what that looks like, and I have a picture of a floppy baby. It's kind of disturbing. Coming out, they just don't have good tone, so they don't get any points for that. If we stimulate them and have to aggressively stimulate them to get a response, then they only get 1 point. But if they spontaneously cry with stimulation, we're kind of drying them off at delivery and it makes them mad and they cry, they get a full 2 points. Activity, if they're not moving at all, none. If they have good some flexion of their arms and legs, they receive a score of 1, and if they have active flexion against resistance, so you can kind of pull on their arms and they kind of resist you, you can tell they have good muscle tone, they get a full 2 points. Respirations, we just check to make sure if there's a good respiratory effort. So absent, 0 points. If they have a weak, irregular, or slow respiratory pattern, they get a 1. And if they have a good, strong cry, they get 2 points. I know that seems like I just read you that slide, but I think it's important for you to know what each of those are, and it might be important for a reason. So circle, star, smiley that if you can. All right, so remember how I said our cardiorespiratory status, our cardiac status, and our respiratory status are super important, and is a really big focus in the beginning days of life? Well, here it is. So we are very much concentrated on their airway at birth. We're looking at their respiratory rate and effort, their breath sounds. Now, breath sounds for a baby in those first 10, 15, 20 minutes, even up to an hour, really can be pretty... you can have those transient rails, like there's junk in there because the fluid might not have all been pushed out right away. If they have a good respiratory rate and effort and they aren't grunting or don't show signs of respiratory distress and they have those rails, then it's a completely normal finding. If they have that plus signs and symptoms of respiratory distress, then that's a problem. And here again are those signs of respiratory distress that we talked about. So tachypnea, retractions, nasal flaring, cyanosis, grunting, asymmetry. Asymmetry we didn't really cover, just meaning is the chest rise equal. If a baby takes a breath and they have on one side or the other they have chest rise and the other side they don't, it can be a sign of a pneumothorax, which a baby is at higher risk for. Color, we're checking for cyanosis. Acrocyanosis is a word you need to know the definition of. Acrocyanosis is blue hands and feet, and that is a normal finding. I repeat, that is a normal finding in a baby up to 24 hours. So if you found a baby at 18 hours of age who had acrocyanosis, their hands and their feet were blue, you would not need to contact anyone about it. You would document that it was present and you would carry on. After 24 hours, then we do get a little bit concerned that maybe this baby isn't transitioning as it should to extrauterine life. So acrocyanosis is a key word that you need to know the definition of. Pallor, So if a baby has some sort of blood loss at delivery, they can become pale. A ruddy color is red. So we see this a lot more, especially with delayed cord clamping, that the baby is ruddy or they have kind of a deeper dark red tone to their skin and their cheeks. That can be a precursor to jaundice, just because we know that they have an elevated number of red blood cells that's making them so red. So we would anticipate that that could then lead to jaundice. Heart sounds, we are just checking for that greater than 100, like we just saw in our APGAR. We do a quick check of brachial and femoral pulses to make sure they're equal on the top and the bottom half of the baby, to make sure perfusion is adequate in both places. Blood pressure, we don't usually do blood pressures on babies, only if necessary, like if they had that PDA like we talked about earlier. And then a capillary refill. We would just do a quick cap refill on these kiddos. Here's that third thing that I told you is most important, thermal regulation. We want to take their temperature soon after they're delivered. We initiate skin to skin with mom and dad. We have dads that do skin to skin a lot, especially when moms have C-sections. We will initiate skin to skin. We set the warmer controls just in case they need to be transported to the warmer at any point in time. If you've got a baby with good APGARs, 8, 9, 10 APGARs, they're going to go to mom's chest as opposed to going to the warmer. If you've got a baby with an APGAR of 2, 3, 4, it's probably going to have to move to the warmer for resuscitative efforts. We probably take a temperature probably about 15 minutes after delivery, and then we reassess it every 30 minutes, excuse me, until stable. And we just make sure that it is stable. We're going to go over routine vitals here in a minute. These are just some standard normal weight, normal length. Please don't commit those to memory. It's not necessary. What I really want you to know is this SGA, AGA, and LGA, so small for gestational age, appropriate for gestational age, and large for gestational age. There's a growth curve on the next page that I'm going to show you. You need to know how to use that growth curve. You'll see it again. I do have the ability to put attachments into the Blackboard testing. The head circumference of babies and chest circumference, we still do head circumference, not as much anymore with the chest circumferences. Some places are still doing it. Head circumference especially is important if that baby has a lot of molding or has had some kind of birth trauma to their head, that we need to keep an eye on for bleeding and such into their scalp. So that would be a reason that we would need to do that. You don't need to know the averages that I've presented here. It's just too many numbers. So here's that growth curve. I do want you to take a note, star this, that the fact that this is a male, this is an example of a male chart. They do make a chart for females. What you're going to do is you're going to take the documented gestational age, so 39 weeks and above is usually a good baby. 40 weeks is term, but 38 weeks to 40 weeks, babies do very well. We don't really consider a 38-week baby a preterm baby. This 2-week baby, this 2-week window here, those kids do completely fine. There's not as big of a difference between a 38-week baby and a 40-week baby as there is a 35-week baby and a 40-week baby. Very big difference there. So say your baby is 39 weeks gestation and it weighs 3,600 grams, so you would come up to where that line meets, and this baby is above the 50th percentile. So this baby is AGA. Above the 90th percentile, that baby is too big for its gestational age. It got too much food, or its mom was a gestational diabetic. Something happened there where that baby is too large for how many weeks gestation it is. Below the 10th percentile is SGA, or small for gestational age. Those babies can also be moms of gestational diabetics. And also babies who had something called IUGR, or intrauterine growth restriction, meaning they didn't get the nutrients in utero that they needed in order to develop properly. So we'll talk more about these and when we go into abnormal newborn and the risk factors for each of these a little bit later in the slide show. But it is important that you know how to use this. I would recommend, if you're taking an exam, to put a piece of paper along this line and then map out your other one so you can see where it falls. So for instance, if you had a 36-week baby that weighed 3,600 grams, that baby's LGA, as opposed to a baby who's 39 weeks and weighs 3,600 grams, that's AGA. And if you had a baby that was 37 weeks and maybe 2,200 grams, 2,200 grams, that would be an SGA baby because it falls below the 10th. So if you need help like maneuvering this or interpreting this grid, we can talk about it at another time. But all right. Medications. So these are medications that need to be given to this baby at delivery. Oh, with the graph on the prior slide, that is done as soon as we weigh the baby, which is usually about an hour at the latest. Medications that we give the baby, these have to be given within an hour. That's why it kind of sparked my memory there about the graph in the previous slide. These medications we give at the 1 hour mark. We usually try and let mom bond with that baby for a good hour before we do anything with it, as long as it's stable. But vitamin K, we'll give that. That's given IM into the right or left thigh. We just have to document it. It's 0.5 mLs of fluid that we give in the thigh. All babies get erythromycin eye ointment. This is to prevent against eye infections from a vaginal delivery. So vitamin K and erythromycin are standard. All babies get that. But again, we are seeing more families that are refusing it. Then they have to be counseled. Then, it's kind of a process. Social services, CPS, blah, blah, blah. But most babies receive this. It's a New York State mandate. Hepatitis B is an option. Okay, so we give them the option to give their first hepatitis B vaccine in the hospital within 12 hours of age, or at the pediatrician's visit the first time that they go. They have to give consent. That's a really important factor prior to giving a hepatitis B vaccine. They have to sign a consent form. We give it in the opposite leg of vitamin K, so they have to get 2 sticks because we don't want to put vitamin K and Hep B in the same thigh. It's a very small thigh, so we want to spread them out a little bit. And they don't have to do the Hep B. If they don't choose to do it in the hospital, there's really no point in doing it, later than the 12-hour mark. They see big benefits of getting it within 12 hours of life. So otherwise, they can get it at the first pediatrician's visit, and it can save them a stick because sometimes they combine it with another vaccine at that visit, so they can get 2 in 1 shot instead of, splitting it at birth into 2 shots. So let's start with our routine normal physical assessment. So this, you're going to do a head-to-toe assessment thoroughly like this at birth. Okay, you want to check that baby at least by 1 hour of age. If you're a nursery nurse, you're looking at the important things, immediately when that baby comes out. And then you're going to do a really thorough assessment at least by an hour of age or at 1 hour of age. And then you will do this assessment per every 8 hours until the baby is discharged. So when we do our head-to-toe assessment, I'm going to start out by saying that there's a lot on these slides. I want you to focus on what's normal. If there's something in the abnormal section that I want you to know, I will point it out to you. So don't get too overwhelmed by the fact that there's a lot on here to know. We're going to mainly be focusing on the normal aspects of the newborn. So overall general appearance, when you first walk into that room, what's the baby doing? Are they awake? Are they eating? What behavioral state are they in? Maybe they're showing signs of hunger that we can initiate a feeding session. What are their extremities doing? So are they well flexed? Meaning, are their legs and their arms bent and showing that they have good tone? Some babies in that deep sleep state will not be flexed. They're going to be relaxed, and like I said, you can kind of pick up their hand or their foot and then kind of just flop back down. Flexed is usually when they're awake and you're kind of messing with them, changing their diaper, changing their clothes, taking the blankets off, Are they moving all of their extremities equally? Do they have a strong lusty cry? We look at subcutaneous fat as an indication as to whether or not that baby is full term. So we like a little bit of a chubbier baby. It indicates a good healthy newborn and a full term newborn. And then we're also taking note of any anomalies that could be present. I want you to pay attention to this word flaccid down here. Flaccid is the opposite of flexed, and on the next slide there's a good picture that demonstrates that. So we're going to move on to that. This is a baby that's well flexed. You can see his legs are bent, his arms are bent, he's got good tone and muscle tone in his body. This baby, however, is not. The baby in picture B is not. He has got probably a lot more going on than just bad tone. He looks like a pretermer. He also looks like he's either preterm or he's IUGR, meaning he had some intrauterine growth restriction and now is SGA, too small for his gestational age. He's also got some modeling going on here of his skin, so we could be concerned about cold stress and perfusion issues. This baby has good subcutaneous fat. This baby does not, here on the right. So we can, determine the term of the baby, the gestational age of the baby, and just by kind of doing that general appearance. This kiddo also, this isn't part of the assessment, but this is a thermometer probe. You guys aren't probably going to get the chance to see that in real life, so I wanted to show you that. And then this is a heart monitor, so this baby's got some stuff going on. And I also would take note, we always have 2 bands on newborn babies, and that is part of our assessment to make sure that they have 2 bands on them. Sometimes we have them on both feet, like here, and sometimes we put one on the wrist and one on the foot, and then on the opposite leg we'll put something called a hugs tag. The hugs tag is like a little baby low jack. If they get close to the door, an alarm will sound and the door will lock, because all OB units are locked units. A Ballard score, I don't want you to get too crazy about learning about the Ballard score. I more so want you to know a Ballard score is used to determine gestational age, so that they can do a very specific assessment. It's got lots of different categories in it. It's a lot to know. Please don't go crazy. I'm more concerned about these physical characteristics in terms of pointing out, some of the more common things that you would say, this baby doesn't look like it's full term, it looks like it's a preterm baby. So skin, we talked about how their skin is thin and fragile, even with a term normal baby, but a preterm baby, their skin is almost translucent. You can almost see through it. And then lanugo is hair on their body surface, and that's more common in pretermers, but it can be a normal finding in different ethnic groups as well. Plantar surfaces is another one. So if you are assessing a baby and you see that they don't have any creases in their hands or their feet, that is an indication that they are a preterm kid. And then genitals, we'll talk about that more when we go to, we're going to talk about that more in a future slide, but there's lots of things about the genitalia that tell you whether or not a baby is preterm or full term. A Ballard scoring is 10 to 50. The higher the score, the greater the gestational age. And when we do a Ballard score, we're, assessing the gestational age and the infant size. We want to know if that baby is small for gestational age, large or appropriate, or average for gestational age, which is in that previous slide there. Monitor for complications common to age and size of the infant. So once we've determined that a baby is either term or preterm, again, dates can be wrong, so we need to treat according to what we assess the baby's gestational age is versus what their documentation says the baby's age is. All right, so vital signs. After we do a general overview of what that baby looks like, we start with vital signs. Just like with adults, I usually do the least invasive for last. So I always do my temperature even after I've done all of my head to toe assessment, especially because the temperature kind of makes them mad. But when we're talking about the frequency of vital signs, we're going to do them every 30 minutes times 4, or every 30 minutes until they're stable. So whichever comes first. If they're stable at the end of that fourth 30-minute vital sign, then we can stop doing them every 30 minutes. We transition to Q 1 hour times 4, and then we go to Q 4 hours until 24 hours old. And at that point, if they're stable, they can transition to every 8 hours. So we assess their heart rate. A normal infant heart rate is 110 to 160. You need to commit these vital signs to your brain. So 110 to 160 is a normal infant heart rate. It's pretty quick. There's some simulations that you guys are going to do, virtual simulations that you're going to do, that are going to tell you, kind of let you listen to a heart rate. It's very quick. It's a little bit of a, it's definitely a skill to get used to, counting that rapid rate. And then a respiratory rate is usually around 30 to 60 breaths per minute. Anything greater than 60 we're considering to be a sign of respiratory distress. Temp is 36.5 to 37.5 Celsius. And we always do an axillary, remembering that an axillary is going to be 1 degree less than what your core temperature is. So if we did get a funky axillary, we could do a rectal, but as a rule, we don't really do rectals unless they are necessary, because they can stimulate the vagus nerve and cause a decrease in the baby's heart rate, which we do not want to do. And as I've mentioned before, the blood pressure is not standardly taken on newborns. But just for a good frame of reference, 80/50 is a normal blood pressure for a newborn. You don't have to really know that. Extremities, when we assess extremities, we're making sure that all of these things are normal. Arms, hands, fingers, legs, feet, toes, head to toe. We're looking in to make sure everything that's there is supposed to be there, and we don't have extras of anything. If you have extra digits, that is called polydactyly. I would write that down so you know what that term means. And then syndactyly is web digits. I've seen a few cases of this in my career, and it's kind of rare, but it is hereditary. Funny story, I had a patient that the baby was born, and there was a little bit of a confusion as to who the father was, but then the baby came out with 6 fingers, and she said, oh, I guess I know who the dad is, because the dad had 6 fingers as well. So that she didn't have to do a DNA test at that point. We again are looking for good flexion, symmetrical movement. We're going to check, we don't check the palpable brachial and radial pulses. Mainly the NPs and PAs will do that. Reflexes are important. I would highlight these and know what they are. The moral reflex, or the startle reflex, is when the baby, I have pictures on the next slide, whenever there's a loud noise or the crib is kind of bumped, the baby kind of acts scared, like they kind of flail their arms up, like they flail their arms up and they kind of get stiff. A palmar reflex and a plantar grasp. So palmar is anything that you put in the baby's hand, the baby is going to wrap their fingers around and grasp that. A plantar grasp is if you put something underneath their toes, they will grasp that. And then a Babinski, you kind of do a sweeping motion up the side of the baby's foot and underneath their toes, and they kind of flail their toes out. Again, I'll show you the pictures on the next slide. The palmar and the plantar creases, we want to make sure that they are present. Slightly bowed legs are normal, and then we also check femoral pulses. The only thing down here that you really want to know is polydactyly and syndactyly, because we do see that from time to time. So here are the reflexes. A is that moral reflex, or a startle reflex. B is the palmar reflex. C is the is the plantar reflex, and then this is the Babinski in D. If you kind of sweep up the side with your finger and across towards their big toe, these toesies will flail out. It's really cute. These over the first year of life disappear. They are not always present after the baby gets older. Integumentary, so checking their skin, it should be smooth. They should have good elastic turgor, an abundance of subcutaneous fat. Peeling is normal after 24 hours. They've been in a hot tub for a long time and then their skin dries out. I always tell parents they can use anything that's meant for a baby on the areas that are peeling. Milia is a term that you should know. Milia is when a substance called vernix. So vernix is when the baby is covered in, it's a kind of a cream cheese kind of consistency in utero, and when they're born, they can have it in their creases. If they're the more vernix they have, the more preterm they are. So we don't see, in term babies, we'll see some vernix and it'll be kind of in their creases. We don't wipe it away. We let it reabsorb into their skin. It's really good for their skin. The milia is when the vernix kind of gets stuck in the baby's pores in their face. I have a picture on the next slide that I'll show you. Lanugo, like I said, was the hair. Modeling is not, again, there could be some perfusion issues there. That's not necessarily a normal finding. Lanugo is more in a preterm baby as well. Erythema toxicum, or normal newborn rash. We also call them ETs. Those are completely normal. They are little red spots on the baby's skin with a little white dot in the middle. I'll show you a picture on the next slide. It's a normal finding in a baby. They come and go very quickly. Mongolian spots are a darkening of the baby's skin, typically found above the buttocks, above their sacrum, and it's usually in babies with darker skin. And again, there's another picture of those. Here we go, telangiectic nevi, don't make fun of me, are stork bites. So those little red patches, they're often around the baby's eyes or forehead. They're completely normal as well. Sometimes they lighten over time. I also see those at the nape of the baby's neck sometimes. Acrocyanosis is a word you need to know, as we talked about before. Completely normal in the first 24 hours, just a slight bluish to their hands and their feet. Jaundice is the only thing really down here that I would prefer that you remember. We'll talk about some other things as we go on. So here's some pictures. This picture up in the top left of the baby's foot, that's just demonstrating acrocyanosis. You can see that bluishness to their foot. Over on the right hand side, that's a port wine stain. That's not on your slide, but that is, it's not an abnormal, it's an interesting finding, but it's not abnormal. We do see them. It's not necessarily a bad thing, but it's a pretty decent birthmark. And then in the bottom right is milia. So you can see in that baby's pores there's a little white spots. That's milia and vernix that's caught in there. And then over here on the bottom left is normal newborn rash with the red and then the white dot in the center. The red and then the white dot in the center. This one is very prominent. They're usually over the trunk, the thighs, the back, and the butt. Occasionally I see them on their face. This is Lanugo. You can see that furry baby. We had a baby like this in my family. We called her Sasquatch for a few years. She didn't appreciate it, but it's really cute, actually. They even have some of this on their ears, the tops of their ears. They'll have hairy ears. They're just adorable. I think it's fine. And then this baby has stork bites, so you can see the stork bites on the baby's eyes. This baby's got other stuff going on too. It looks a little pale. I would suspect a little bit of blood loss from delivery. The head is either round or slightly molded. Round heads, usually you only see a really round head if a baby came out very quickly or if a baby was born via C-section. Molding is when the plates of the scalp kind of form to the shape of the vaginal canal because it's been stuck in there for so long prior to delivery. A first-time baby takes at least 2 hours usually to push out. So if you've got a head that's sitting in that 10-centimeter hole for a while, that head has to mold to the shape of that in order to be born. So that's a normal thing. It usually goes away within a week or so. They lose that cone head shape. And then also the sutures of the the palates of the skull can override too, and that's a completely normal thing to find. So star circle smiley that. Capit is something that you need to know about. Capit is when the baby is repeatedly pushed against the cervix in labor, which all babies are, but some babies develop a little bit of swelling. It's just fluid. It's like edema in the legs or anywhere else in the body, and it's squishy to the touch. It's only fluid, whereas the cephalohematoma, which is one thing down here that you need to know. A cephalohematoma is blood. And I'm going to show you in the next slide how you differentiate between capit and a cephalohematoma. So in terms of the head, you need to know round, if it is molded, if there is capit, and if there's a cephalohematoma. Again, a cephalohematoma is like a big bruise. It can often be caused by birth trauma. The other thing we're looking at is those fontanelles. We have an anterior fontanelle and a posterior fontanelle of the baby. The anterior fontanelle is shaped like a diamond, and the posterior is shaped like a triangle. This one's harder to find, especially if there is lots of molding present. Sutures the sutures between the plates of the skull can be slightly separated or overlapping due to molding. We want to make sure with the fontanelles, if they're bulging, that can be an indication of hypervolemia or hydrocephalus or increased ICP. And then sunken fontanelles can be a sign of dehydration. So we assess those. We want them to be soft and flat. That's the documentation that we indicate for normal fontanelles. So this is a cephalohematoma. So a cephalohematoma, as you can see, is blood. And how you can determine whether this head is a cephalohematoma head or a capit, or if it's just capit, is that cephalohematomas are only on one side of the baby's head. So you can see the blood, there's a membrane here that separates the two sides of, the two parietal bones, and this membrane blocks the blood from going onto the other side. If it's capit, it's going to be the whole surface of the head, as opposed to just one side or the other. So that's how you tell between capit and a cephalohematoma. Eyes, we just want to make sure that they're symmetrical, there's no pseudostrabismus or chemical conjunctivitis, so any kind of eye infections. We want to make sure that the cornea is clear and they have a blue-white sclera as opposed to like a jaundice. Yellowing of the sclera is pretty advanced jaundice, so I would hope we would pick up on their jaundice prior to their sclera becoming yellow. They can have a subconjunctival hemorrhage, or it's basically just a popped blood vessel in their eye from trauma of delivery. Moms can get that too from pushing. Absence of tears. It's normal, they say, for a baby not to have tears for the first 2 weeks of life. I swear I see babies have tears prior to that. I've seen tears develop before then. And then doll's eyes movement. You can click on that video to watch that, but when you lay a baby doll down, their eyes closed, and you pick them up, then their eyes open. You can watch a demonstration of that in that link. There's a link there. Nothing down here that you need to know. Ears, we want to make sure that the pinna of the ear, so the top of the ear, is at or above the level of the line draw from the outer canthus of the eye. So we want to make sure at the corner of the eye, when you go directly across, that the pinna is at or above that level. If they are low set, that can be an indication of Down syndrome. And we also can check gestational age by assessing the ears, because a baby who is term, if you fold that ear down against the head and pop it back, it will pop back up on its own because it has enough cartilage to do so. A preterm baby doesn't have that cartilage. We do check behind the ear lobe for a periauricular sinus. There can be it's neural tube defect there, that you can have kind of a hole where you can have fluid that drains from it. There's good pictures in your book and on that website of a periauricular sinus. I've never seen one before. The nose should be midline. It can appear flat, but usually it's flattened because it's been smushed up against the side of a uterus for a while, and it goes back to normal. Occasionally babies sneeze. Parents get really worried about that. It's completely fine. If they have excessive sneezing, it can be a sign of drug withdrawal. Things down here on the bottom, obviously we've talked about this a little bit, but nasal flaring and grunting, you should really know, are signs of respiratory distress. The mouth and the chin are important to assess in relationship to feeding. You want symmetrical movement. You want to put a gloved finger in their mouth and check to make sure that their lip they don't have any cleft palate or cleft lip or hair lip. So you want to assess that. That's important to assess. That's one of the first things that we assess, actually, in that first 10 minutes, because we want to be sure that we are not feeding a baby that has some sort of cleft palate. Epstein pearls, those are little white specks. They're usually on the back of the throat, on the top of the roof of their mouth, sometimes on their cheeks. They're just little white, they look like little pearls in their mouth. They're completely normal. They go away on their own. Parents freak out about them, but they're a normal finding in a newborn. Making sure that their tongue is mobile, and that they don't have a tongue tie. So babies who have a tongue tie can have difficulty feeding, and then if it's not corrected, can have difficulty with speech later on in life. Depending on the physician, they may or may not clip it. There are, different schools of thought where if you don't clip it, it'll stretch on its own. Eventually, I'm a fan of clipping them because I think you're setting them up for failure with breastfeeding. It just means that their tongue cannot stick out fully to surround the nipple, and then they can't perform the correct motion to draw milk out. So if you're not getting good enough milk withdrawal, then they're not getting the nutrients they need, and then you're not going to have good milk production as well. So we'll talk more about that when we talk about infant feeding. Sucking pads on their cheeks. Babies have very thick cheeks because they are built for sucking out milk from a breast. Reflexes related to this are rooting. Rooting is a sign of hunger. So rooting is when you touch the side of the baby's mouth and they kind of turn to that side. They kind of open their mouth and they're gaping. They're looking for a nipple. They're looking for food. Sucking is a reflex, which is a good thing because it helps them to eat, but it is also something that parents sometimes they don't understand that it's a reflex and not a sign of hunger. So if your baby is formula feeding and you put the bottle in their mouth and they suck away, it doesn't necessarily mean they're hungry. They'll suck that whole bottle down and then they'll puke it back up because it's too much. So you can't say, oh, he's just sucking so much and he's so hungry. That's not always true. It's just a reflex. If you put a gloved finger in there, they're going to suck on it. Swallowing is a reflex, and gagging is a reflex as well. So E is a picture of this baby rooting. This is the rooting where they're touching the side of the baby's mouth and that baby's gaping for food. And then F is just demonstrating a suck. The baby's neck is typically short. We just want to make sure they have good range of motion. They're turning their head back and forth, side to side, and they do tend to have an ability to lift their head up momentarily, not for an extended period of time initially when they are a newborn. Their chest, they should have symmetrical excursion, meaning they can push air out of their lungs equally. We don't have any, one side that doesn't rise, as we have discussed. They're at high risk for a pneumothorax, and that would be a sign of that. Breath sounds should be clear and equal. Transient rales at birth, as we have discussed previously, are normal. They should resolve within the first 6 hours of life. They can sound a little wet at the beginning, completely normal finding. Rounded chest, breast engorgement, like I said, is a normal finding in a term baby. It's a transfer of hormones from mom to baby at birth. And then transient murmurs, so that's that PDA that we were talking about, 24 hours. A persistent murmur beyond that point in time we would be more concerned about. And it is reportable even though it's normal, just because we want to keep a close eye on it. Down here on the bottom, retractions is a big one related to respiratory distress. The abdomen should be rounded and soft. We listen for all four quadrants for bowel sounds, just like we do in adults. There should be 2 arteries and 1 vein in the cord. Okay, so when you're assessing the abdomen, you want to look at their umbilical cord, and especially at birth, we're checking for 2 arteries and 1 vein. You might want to remember that, circle, star, smiley, that 2 arteries and 1 vein. And I always remember it as AVA. So AVA, 2 arteries, 1 vein. We also assess the amount of Wharton's jelly on the cord. Thick Wharton's jelly around those vessels indicate a healthy pregnancy and good nutrition for that baby. So making sure that Wharton's jelly around the vessels, it's just a clear gelatin like substance. It's very thick. It's surprisingly difficult to cut. 1 artery instead of 2 arteries. Okay, so if you had a cord that's a 2 vessel cord, 1 artery and 1 vein, that is associated with renal issues. And we do see this sometimes, that they have this, and we send them to ultrasound to check out their kidneys. We don't necessarily send them for a heart ultrasound or echo, but I do see them a lot send them for the renal. So that's just something that I just have a little bit of experience with. So the genitals, so in female genitals, this, again, a lot of this is, you can identify whether a baby is term or not. So in a normal term baby, the labia can be slightly edematous, and it can cover the clitoris. It should cover the clitoris. The labia should cover the clitoris. In preterm babies, the labia does not, so the clitoris is visible. Pseudomenstruation is a normal finding in a term baby. It's a little bit of blood in their diaper. It's like a false period. That's what that kind of means. And they get that as a result of a transfer of hormones from mom. With little baby boys, we are checking the penis with the foreskin if it's present. Sometimes babies are born with what's called a natural circumcision, where they're born without the foreskin. The meatus, we're checking to make sure it comes out to the middle or the tip of the penis. If it does not come out to the tip, the middle of the tip, then we are assessing for either an epispadias, where the meatus comes out to the top portion of the penis, or a hypospadias, where the meatus goes out to the bottom. Both of these need to be fixed. Obviously, you can have some difficulty with aim when voiding, so we do want to correct that. And then later on in life, if this goes untreated, you can have difficulty with fertility as well. So an epispadias and a hypospadias is something that you need to know the definition of, and also know that if you find a hypospadias or an epispadias, you cannot circumcise that child. They have to be circumcised outside of the hospital, because they use the foreskin to repair those anomalies. They'll be done by a special urologist. We check to make sure that the testes have descended into the scrotum. There can be some slight edema of the scrotum as well. That is normal. If there's a lot of edema, that's called a hydrocele. And a hydrocele is just excessive fluid in the scrotum. The big risk with a hydrocele is we have to make sure that the testes, if there's extra room in there, the testes can actually, you can have a torsion, they twist and it cuts off blood supply, and the testicle can actually die. So if we find a hydrocele, we keep a close eye on it just to make sure that there's no necrosis or darkening of the tissue of the scrotum that would indicate that there was a torsion going on. Rugae of this on the scrotum indicate a full-term baby. So that rugae presence is again on a full-term baby. Rugae is not present on in terms of being a preterm baby. So that's an indication. I always think about differentiating preterms to terms is that they're preterm babies are lacking the details of what a term baby would be. The newborn's back, hips, buttocks, and anus also need to be inspected, so I usually roll them flat over onto their belly and put their head to the side. Some babies like to be on their bellies. We don't recommend it, but they have to be. The spine, we're assessing to make sure that the spine is intact. They have symmetrical gluteal folds, so when you fold them onto their belly and you're looking kind of at the area between their butt and their knees, there has to be symmetry between those folds. If there's asymmetry, that can be an indication of Down syndrome as well. You want to make sure that their limb length is equal and they have a patent anus. Usually we can tell if the anus is patent if they are pooping. So the first stool usually clears them of that finding. We want them to poop by 24 hours of age. So beyond that, we would be concerned that there could be an issue there. Okay, so that concludes our head to toe assessment. And again, those are done at those times. The vital signs and the complete head to toe assessment, after 24 hours, they'll be done every 8 hours, and as needed for changes in status. So suppose you walk in and the mom says, oh, the baby hasn't had a bowel movement yet, and the baby is 27 hours old, whatever, over the 24-hour mark. You're going to have to assess things on the fly. So you might listen to bowel sounds, you might ask about feeding, how often are you feeding, how long is the baby attached to the breast, or how much formula is the baby taking. So what I'm saying is, even though we do a complete head to toe assessment every 8 hours, we are continuously assessing these kids every time we walk into the room. You're looking at the baby, looking at their color, looking at their tone. We are very lucky in our small community hospitals to usually only have a limit of 3 mother-baby couplets at one time. So that's 6 patients essentially, because you assess mom and you assess baby in each of those rooms. And we're lucky to only have 3 moms and 3 babies, and that is a pretty heavy assignment, but we know what's going on with these kids. On a good day, you'll have 2 moms and 2 babies, and you really know every step of the way, peeing, pooping, activity, and you're just continuously assessing every time you walk into that room. So that's part of our ongoing assessment until they go home. We're going to talk about infant bathing, cord care, circumcision, intake and output, monitoring for jaundice, monitoring for blood glucose changes, and assisting with feeds. And then teaching, we're continuously teaching. I think this is one area in nursing that teaching is so, so important. And I think parents expect that. We used to do a lot more teaching, even more than we do now. But their short and length of stay limits our ability to do that. You'd be surprised the number of couplets who come in and they've been pregnant for 9 months and they haven't done much research on how to care for their kiddo. So we do teach them a lot before they go home. The infant bath, we wait to bathe every baby according to the policy at the facility. The facilities that we would be in are 24 hours. You can't bathe a baby before 24 hours. Studies show that that period of time is what is necessary for the baby to be stable temperature-wise in order to bathe them. If parents want to wait longer, they can. We have babies that go home without having a bath and they want to do the bath at home. That's completely fine. But the big part is infection control on our side of things. If a baby is not bathed, you need to have a pair of gloves on to take care of them. When we go to take the tub or to do the bath, we check their temperature initially to make sure that it's stable before we start. We maybe increase the temperature in the room to avoid heat loss. Make sure the water's warm enough. We do involve the parents, and after the bath, we want to place the baby skin to skin to help that temperature be maintained, and we recheck it then an hour after. The facilities that we work in, the temp recheck after the bath is 1 hour. When you're performing the head to toe, the bath head to toe, you're going to start with cleanest areas first. So we start with the face. We don't put any soap on the face. You just do water on the face. You're cleaning the eyes from the inner to the outer sections, and then you will clean the baby arms, trunk, legs with soapy sudsy. If you're not making a mess, you're not doing it right. And then we'll do the butt last, the bottom and the genitalia last, because that is the dirty part. I usually flip them over and clean their back after that, and then I also you dry them off good. After all of that, you dry them off good. Put a diaper on because they pee on you. If I had a nickel for every time I was peed on after I gave a bath, and then we do their hair. So we wrap them up tight, and then we usually put them kind of over by the sink, and we'll kind of do the warm water on their head with soap, and usually we'll have to do a comb and get some of the delivery gunk out of their hair if they have long hair. Cord care. So we're assessing that cord when we look at the abdomen. The cord typically falls off within 10 to 14 days. We cannot do any tub baths where the baby's cord site is submerged under the water until the cord site is healed. You can clean the base of the cord if it is soiled. Otherwise, our primary care is to keep it dry and free of irritation. So we fold that diaper down initially until the cord is fallen off and the site is healed. And then we always send parents home teaching them the signs and symptoms of infection. Cords can look a little gross before they look better. Gross, it's such a technical term, but they can be kind of oozy when it first falls off. It takes a couple days for that to go away. And then we're focusing at the base of the cord. You want to make sure that skin isn't red or warm to the touch. Circumcision, the most important part is informed consent. We have to go with the risks and the benefits. Again, it's not about our opinion. It's probably about 50-50 these days, actually, who decides to circumcise their baby. Benefits, infection risk, STD risk later in life, and a lot of times, really, they choose, if dad's circumcised, then the baby gets circumcised. And I see a lot of moms just leave it up to dad what they want to do in terms of circumcising their kids. Risks associated with circumcision, the two biggest ones are bleeding after, because it is a surgery. It's a minor surgery, but there's always a risk for bleeding. And then also infection, same thing, small surgery, but still a surgery nonetheless, which means there's a risk for infection. Contraindications would be that hypospadias and epispadias, or babies with Downs actually cannot be circumcised. They can have some strangulation issues if you don't care for it well. So we do not recommend that babies who have Down syndrome get circumcised. Pain management, we give them Sweeties, which is a sugar water. So we dip a pacifier, if the parents are okay with a pacifier, in Sweeties and let them suck on that. It's like a lollipop. If the parents don't approve of a pacifier, we can use a gloved hand. We numb the penis at the base of the penis on both sides. It numbs the entire shaft and the tip. so that they can perform the procedure. We also play music for the babies, and we also swaddle them pretty tight. Most of the time they don't, the pain, they're not crying because they have pain, they're crying because they don't like to be strapped down to the circ board, which looks pretty inhumane, honestly. The two methods that they use are a Gomco clamp and a Plastabell ring. So we don't see the Plastabell around here. The Gomco clamp, it is what we will see in our hospitals. There's a Mobitz now too, and that's pretty, it's quicker than the Gomco, but they both use instrumentation. Both of them involve crushing blood vessels to prevent bleeding and then removing the foreskin. It's kind of hard to describe the whole process without being in front of it. The Plastabell ring, they apply it, they tie it to the baby's penis, and then they let the skin die off after they go home. So they go home with this, and then the foreskin kind of just falls off. They actually say that that's a better method. It comes out better, but I can't imagine being a new mom, having to deal with that. That might be a little bit traumatizing, I would think. But circ care, after the circumcision is done, we do a circ check in 1 hour. Glens Falls does circ checks every 15 minutes for the first hour, so you would want to check your facility's policy on that. We use Vaseline with gauze, so we do an ice cream cone around the tip of the penis of Vaseline. You're very generous with the Vaseline, and then we do a PPTP and put gauze on either side. This is just to prevent the penis from drying, that blood from drying against the diaper, because then it can kind of get stuck and then it hurts and it's not good. So the Vaseline, and we do that for 24 hours. After the 24-hour mark, they don't have to use the gauze anymore. They can just use the Vaseline where it meets the diaper. And all of this we teach to the parents so that they can care for that circumcision once it's complete. Intake and output, we talked about the progression of stools, but we didn't really talk about how we measure their intake and output. So voiding, we count the number of wet diapers. Stooling, we count the number of dirty diapers. The number of pees and poops each day. Day 1, 1 pee, 1 poop. Day 2, 2 pees, 2 poops. Day 3, 3 pees, 2 poops, all the way up to day 6. We would like to see 6 pees and 6 poops. That doesn't mean if they have 6 poops on day 2 and 6 pees on day 2, great, that kid's ahead of the game, they're getting enough nutrients. Voiding and stooling is how we measure if they're getting enough in to be able to then excrete urine and stool. So that's one measure of how we know that they're getting enough. The amount on term normal babies for both voiding and stooling is just it's a guess. It's a guess. Is it a small amount, a moderate? It's approximate. I wouldn't say it's a guess. It's approximate. Babies who are preterm, we weigh diapers and measure it that way. We do a stricter intake and output. With voiding, we're going to indicate the presence of uric crystals. Uric crystals are kind of an orange tinged to the urine. It can indicate dehydration. It's a normal finding in breastfed babies. Breastfed babies tend to be a little bit drier the first couple days than formula-fed babies do. We indicate the type of stool, so meconium, transitional, that yellow CD or yellow mustard. Emesis, we always are accounting if the baby has any regurgitation, whether it be mucus, which is very common if a baby isn't in the birth canal for a very long time. Maybe it's a second or third baby and it comes out very quickly. They don't get that squeeze, so they can have some mucus in their airways. C-section babies don't get a squeeze either, so they can be pretty mucusy. Colostrum is what's present those first couple of days, and when they throw that up, it's kind of like a bright yellow-green color. Formula, it looks more of like a brown tan tinged, and then sometimes they have old blood present, and that's just from delivery. Sometimes they can take a gulp of blood and then it kind of sits in their belly and they puke it up and it looks like dark coffee grounds. It can be normal, it just can be from delivery. We also estimate the amount of that as well, of any emesis that they have. Visual observation on assessment of jaundice, again, begins at 5. We do not want a transcutaneous bilirubin. So a transcutaneous bilirubin is minimally invasive. It's a monitor that they put on the baby's head, and it takes a bilirubin level just from touching their skin. This is routinely done at 24 hours, and again, we don't want this to be above 8. And then we also do it the day of discharge before they go home. And we can do it more frequently if we think that that baby is becoming more jaundice. Click on this link. It's called Billy Tool. And Billy Tool helps us to determine if a baby is at risk due to their jaundice level. So if you had a baby that was greater than 8, you would have to then do a total serum bilirubin, a serum meaning a blood bilirubin. And we would plug those numbers into Billy Tool, and it would tell us if they needed phototherapy or not. High risk, low risk, high intermediate, and then also even Billy Tool will give us a hint, and then the physician will determine whether or not they're really going to initiate the phototherapy or not. The total serum is a heel stick, and we send that to the lab, and it's a combination of indirect and direct, or unconjugated or conjugated. So how much has been conjugated to be excreted in the blood, and how much is still floating around left to be processed by the liver, to be transported out of the body. Direct bilirubin we don't see as much. That's just conjugated. Usually they want the TSB. But remember, 24 hours, the level is 8. It should be below 8 at 24 hours. Prevention and treatment, we want to feed these babies frequently to prevent jaundice. Again, putting food in is going to help them to excrete it out of their bowel. Exposure to sunlight, it's harder to get that in the winter months, but sunlight does exactly what phototherapy does, at a slower rate. And sometimes they say that because we're in the Northeast, we don't get enough direct sunlight to really make a huge difference. And then phototherapy would be the ultimate intervention that we would initiate, and that is the baby under the blue lights, and it's usually a period of time, and they do repeat TSBs to see how the baby's progressing, if that jaundice level is coming down. In relationship to baby's blood sugar, there's a lot of reasons why we would take a baby's blood sugar, but hypoglycemia is one of the things that we're really looking for. And remember, a low temp can indicate a low blood sugar. If they have a low temp, they're going to burn up that blood sugar quickly, the sugar in their body quickly. A level below 40 is a problem, so that's abnormal. We obtain it by a heel stick and a one-touch machine. All of these infants here are at risk, so pre and post-mature babies, so preterm and post-term babies, late preterm babies, babies who are IUGR, which is intrauterine growth restriction, babies who are LGA or SGA, babies who have asphyxia at birth, babies who have birth trauma, babies who have cold stress, and babies of mothers that have maternal diabetes, whether it be gestational or pre-existing. The signs and symptoms that you need to know to pick up on hypoglycemia, the main one is jitteriness or tremorous. They kind of shake a little bit. It's just like us. If our blood sugar drops, we get a little bit shaky and jittery. They have a low temp. You might want to check a blood sugar. This one is a later sign. If they're lethargic, then we've missed it, okay? And they can be, that's a little bit further. So usually they have a really low blood sugar at this point. Irritability can be a sign, as well as they can be asymptomatic. Yay! So we don't routinely check babies, even though this is a possibility. SGA, LGA infants of mothers with diabetes are routinely screened. All of these babies will get a blood sugar at 90 minutes of age, right off the bat. we want to do that wait at 1 hour so that we know if the baby is SGA or LGA in order to do the blood sugar at 90 minutes. And then those babies also will get blood sugars every 3 hours for a period of time, depending on, you know, what they are, if it's due to diabetes or SGA or LGA. And we will check it every 3 hours for a period of time just to make sure that they are stable and they don't become hypoglycemic. This is a picture indicating where you can take a blood sugar on a newborn. So on the outer sides of the heel, you want to avoid the center of the baby's heel because this nerve runs right down through the middle. So you want to avoid that nerve and damaging that nerve. So you want to pick the fatty pads on either side of the baby's heel. Okay, so infant screenings. There's a video for each one. I do encourage you to watch them. This bottom one for normal newborn screening is relatively long, but I do want you to just watch the nitty-gritty, watch the important part where they perform the procedure. It's 17 minutes long. Please don't watch the whole thing. But we're going to start with the critical congenital heart defect screening, which is a CCHD. We recently started doing this within the last 3 to 5 years, and it picks up on babies who may potentially have a congenital heart defect before we send them home. It's amazing, and it's very simple. You need 2 O2 sat machines. You put one O2 reading from the hand, the right hand. It has to be the right hand. Okay, it must be the right hand. And then you put the second O2 sat monitor on either foot. It doesn't matter which foot, but it has to be the right hand. When you take the readings, the O2 sats, so you're taking it at the same time, the O2 sats have to be above 95, okay, 95%, and within 3 points of each other. So if you have a reading on the right hand of 100 and a reading on the left foot of 96, that's a fail. You would need it to be 97 for it to be a pass. I love to have 100 in both places, so I usually leave them on until I get that. But that's just me. But they can pass if they are within 3 of each other and above 95. So that is an important screening. You need to know these screenings inside and out. It comes up a lot in exams and quizzes and such. The hearing screen. Oh, the CCHD can be done at 24 hours of age and no sooner. You have to wait till they're 24 hours. The hearing screen can be done at 12 hours. But I will say that we usually wait and do the hearing screen at the 24-hour mark along with the CCHD. And then the hearing screen, we hook them up to this machine. There's a sensor on the forehead, their back, the nape of the neck, and on their scapula. And then we put little earmuffs over the top of them, and it sends waves into their ears, and then those sensors pick up on brain activity that indicate that they're hearing those waves. I'll let you watch the video so you can see how it's done, but again, that one can be done as early as 12 hours. They can also repeat that. If they don't pass by the time they go home, they have to have a referral to an outpatient setting. The normal newborn screen, or the PKU, it's also called the PKU. It used to be called the PKU. Now we just call it the normal newborn screening because it tests for 57 different genetic diseases. It's an early intervention screening tool. And this is New York State mandated. All of these are. New York State mandates these screenings. This is a heel stick, and we take 5 drops of blood from the baby's heel. It's more than 5 drops, but we fill 5 circles with the baby's blood, and it's then sent out to the state. I want to say, in terms of nursing intervention, it's really important when you're doing, so think about the things we've talked about that you can do at 24 hours of age. You can do a baby's bath, you can do the TCB at 24 hours of age, you can do a CCHD, and you can do the normal newborn screening. The hearing screen can be done at 12 hours, but again, we wait usually until 24 hours. So I always make sure that I do my TCB my transcutaneous bilirubin before I do my normal newborn screening. Because if I do my TCB and it's high, I'm going to have to do the serum, do the TSB to verify that. So I save my baby a stick if I do my TCB first, and it's abnormal, then I have to take a serum. So I have to stick them to get the serum blood, and I also have to stick them for their newborn screening. So it's really important that we perform those interventions to minimize sticking the baby multiple times. When we perform a heel stick, I should have said this on the previous slide, but when we perform a heel stick, we always put a hot pack on their foot for a period of time. It warms the area and brings blood there, and it makes their blood flow much easier to collect specimens. Okay, so I promised you a lecture on RH incompatibility, and here it is. So babies, moms rather, okay, so moms who are RH negative, they have to receive RhoGAM. When moms are RH negative and they have a baby who is RH positive, there is a chance that because that baby is connected to mom's bloodstream, that some of that RH positive blood was entered into mom's bloodstream. That RH negative blood is going to react to the positive blood of the baby and create antibodies. Okay, so moms who are RH negative can potentially fight the blood of an RH positive baby. Okay, it doesn't affect the initial pregnancy unless there is some sort of trauma in that pregnancy where blood is transferred early on in the pregnancy to mom's blood. Then they can convert and actually start to attack that in that same pregnancy. But for the most part, we are preventing, by giving RhoGAM, we prevent mom from converting over and making antibodies that fight off RH positive blood for subsequent pregnancies. So if that mom were to get pregnant again and she had made the antibodies in a previous pregnancy because there was some sort of mixing of blood, then that mom would then fight the blood of the RH positive baby, and potentially that baby could die. So because it just destroys the red blood cells in that baby's circulatory system. So it's really important that we identify moms who are RH negative and give them RhoGAM. They get RhoGAM at 28 weeks gestation, and then they get RhoGAM after delivery if the baby's blood type is RH positive. Okay, so that's an RH issue. If that situation occurs, that baby, because there's that risk of transfer and hemolyzing that hemolyzing all of their red blood cells. If you're killing off red blood cells, then you have all those byproducts that have to be filtered by the liver, and you can have hyperbilirubinemia. So moms who are RH negative, we always want to identify if the baby is positive so that we can determine if they're at high risk for jaundice. Okay, and also to give them their RhoGAM to protect subsequent babies in subsequent pregnancies. So that's the RH component that can be difficult. ABO incompatibility is not as severe as RH incompatibility. We don't treat our ABO incompatibility babies. So this is when mom's blood type is O and the infant's blood type is AB or AB. So these blood types, O, A, B, or AB, do not necessarily mix very well, and we can again have hemolysis of these babies' blood, which puts them at higher risk for jaundice. It's not as severe, so there isn't really a treatment. So in review, okay, all infants of O moms and RH negative moms are screened. Okay, so we always check those blood types of those babies. The cord blood is taken at delivery and we test it. So we don't have to stick the baby. We can just take the blood out of the cord that's the baby's blood and test it to see what their blood type is. Rh negative mothers are given RhoGAM throughout pregnancy, so at 28 weeks, and after delivery if the infant tests Rh positive. No treatment is necessary for ABO incompatibility. And all of these infants in these situations are at high risk for developing jaundice. Less if it's just an ABO incompatibility. If it's both, then they are at very high risk for jaundice. So we would watch them even more closely. And that concludes this section of the postpartum segment. So we will continue on next week with postpartum.